Is it visible, sir?
Yes,
Am
yes,
I
sir.
audible?
Yes,
Right.
now yours.
Audible.
My talk today is on non-union both bones forearm. And to begin with, these are the three everyday scenarios which we face as orthopedic surgeons. To the left is a 38-year-old male with infected non-union with plates in situ. Center is a 40-year-old male with a 2-year-old aseptic non-union where the implants have already been removed. Third one is a 50-year-old male where single bone is potentially infected, the radius.
There is
Now,
some background disturbance. Dr. Gupta, is it your end?
not my,
Yes, you can go ahead.
yeah. So, most of the time, the both bone forearm gives us a good result. And as a resident also, we were very excited to fix these. But to achieve good results, you need biological surgical technique, and reported non-union rates are actually less than 5%. But like all other bones, they do go into non-union, and the risk factors can be injury dependent and surgeon dependent. The injury dependent factors, like any other bone, are high energy trauma leading to comminution and open fractures, and surgeon dependent factors can be suboptimal surgical technique and inadequate fixation. Most of the times, both these risk factors are at play, and we have to identify them. Like any non-union, the principles of the management remain the same. In any case of previously implanted bone, and same as with the non-union forearm, you have to have a high index of suspicion for infection. And if the doubt is not substantially alleviated, then there's no harm staging the procedures. Soft tissue concentration, it's not such a common in forearm fractures, but it can be an issue in certain set of patients. During reconstruction, we have to debride the bone to the bleeding ends, and we have to open the canal up. We have to maintain length and radial bow as far as possible for good functional results. Appropriate bone graft and appropriate rehabilitation are cornerstones. Just elaborating on principle one, first, determine pre-operatively whether it is infected or not. Routine CRP, ESRs, and clinical examinations can give you a clue. If in doubt, stage it. And what it requires is a radical debridement with local antibiotic delivery with temporary stabilizations. As the picture can show here, this is our go-to technique where we debride to the transverse bone ends to the paprika sign, put in an antibiotic delivery system in form of a PMMA cement loaded with antibiotics and intramedullary K-wires. Principle two, when you're coming back for definitive reconstruction, the fracture ends have to be carefully prepared and preferably transverse so that you can achieve as good a contact as possible under compression. Osteoperiosteal decortication for 2 to 3 centimeters on either side helps to prepare the bone to accept graft, and open the canal with a drill bit. Typically, a 2 or 2.5 drill bit is used to sound the canal. Principle number 3, and very important, the maintenance of forearm bone length is absolutely important. Especially, one should avoid ulnar variance. As you can see in this picture, ulnar variance is a painful condition and can limit wrist function. Length and radial bow, they have to be maintained as they are absolutely vital for distal radioulnar joint and proximal radioulnar joint function. In this particular patient had a wonderful bony result but had a horrible functional result just because the radial bow was not maintained and the relative positive ulnar variance was achieved. Principle number 4, addition of bone graft is almost essential in treatment of non-unions. Appropriate bone graft is to be used. The bone graft, in case where there is not much defect, is the bone graft of choice is highly expressed, which can be used as a particulate graft or as a strut graft. In a little bigger defect, up to 5-6 centimeters, non-vascularized fibula comes in handy in upper limb. Vascularized fibula with or without cutaneous flap is done in some centers. I have never done that because we don't have the necessary expertise to go ahead with this, but yes, it can be used in defects more than 6 centimeters. Shortening of bones should be kept as a last resort because, as I had discussed earlier, that the function is length dependent. Making a single bone forearm may be warranted in some special circumstances, as you can see in this picture. Now, coming to the rehabilitation, it again remains one of the most important things in management of non-union of forearm. Above elbow splint is worn for 7 to 10 days to allow for wound healing, because in all these cases, the skin is multiple times violated and it needs rest to heal. There is no hurry to rehabilitate and start moving day one. Hypertrophic non-unions treated with plating are allowed early movement. Patients with atrophic and defect non-union, we should go a little slow with the pronation and supination because that can cause implant failure, and any lifting till 6 weeks. Elevation of hand and gravity assisted movement allow for decrease in swelling and stiffness. Passive manipulation by physical therapist is absolute no-no, and resistive exercises only should be added once early callus is seen on x-rays. Now, what do you expect with these treatment principles? A good clinical and radiological outcome in most, but around 20% have an unsatisfactory long-term functional outcomes. And most of it is related to the length and radial bow issues affecting the proximal and distal radioulnar joint. Now, coming back to the cases, the 38-year-old male with infected non-union, that is him at presentation. He had a pus discharging sinus. This is after stage 1 surgery where the bone ends were resected, length was maintained, antibiotic cement spacer was put, KYs were used for intramedullary stabilization. KYs could have been a little longer. Then at second stage, he was plated and a strut fibular graft was used. And this is him at the time of union. He had a reasonable function. There's another patient who was a 40-year-old male who had plating outside, then it was removed. All along it was aseptic. This is him at the time of definitive reconstruction where radius was cut to the transverse ends, fixed under compression, and iliac crest was used as a strut on the ulnar side to maintain the length. And this is him at the end of union. You can see radial bow well maintained, for negative ulnar variance, good function, though there was some shortening that was required on the radius side, but it was. This is a 50-year-old male with a single bone potentially septic. Ulnar is well fixed and united. Radius is not united. When it was opened, the CRP-ASR was okay, but it was thought that it is not very good and required a lot of resection. So in this, definitive fixation was done and a cement spacer was used. Graft was not done in the first stage. And then in the second stage, fibula was added, couple of screws were added and went on to good union. Now to conclude, non-union forearm is a challenging situation. You have to be flexible in your approach. Adequate reconstruction of radial bow and length are paramount for good function and are a cornerstone of a good surgery. When in doubt, stage it. Before I end, I must thank one of my very close friend, Dr. Ravinder Puri, for sharing a couple of cases in this. One of the cases was mine. Two of those cases were from Dr. Ravinder Puri. Thank you so much for your kind attention.